You're listening to FitPro Sessions with Parallel Coaching, Season 4, Episode 6. Hi, I'm Neil Bergman, and in today's podcast, Hayley and I are tackling back pain for clients, so stay tuned.
Hi, I'm Neil Bergman.
And I'm Hayley Bergman. Over the last 10 years, we've helped thousands of fitness professionals to get qualified, learn with simplicity, and coach clients with confidence.
We're the first to say that learning and being a fit pro doesn't have to be hard work, and that with the right structure, support and resources, you can become a confident and knowledgeable fitness professional that is dedicated to more.
So how do you learn, qualify and kickstart as a fit pro? This is the FitPro Session Podcast with Parallel Coaching.
Before we jump into back pain today, I want to make an apology straight out the gates. And that is my voice. So we've just come out of 3 pretty tough days of teaching. And on Sunday night, my voice was absolutely fine. Woke up Monday morning, absolutely fine. Woke up today, we're recording this or parts of it on the Tuesday. And my voice is a little bit croaky. So it's not delayed onset muscle soreness, it's delayed onset voice tiredness. So DOVT. There we go. So there's
a bit of DOVT
I've got a bit of DOVT going on
Mine's
today.
a bit tired as well today, actually. It definitely delayed.
Definitely delayed voice tiredness. So there we go.
I also just want to say thank you for all of your messages and emails and comments about especially the last 2 episodes we've done. So episode 4 was obesity and metabolic syndrome, and episode 5 was all about diabetes. And honestly, the feedback we've had about how much people have learned inside those sessions.
It's amazing. And you know, if you go back to say the first season, which was 48 episodes, there was week on, week out growth. And then in season 2, which was all about becoming a fit pro, again, you could see more growth each week. And then in season 3, where we did 2 episodes a week. Yeah, just listening and giving feedback. But it's this season where the feedback comes in on all of our social channels. We're getting more 5-star reviews. People are saying thank you. They're emailing in. And you're learning so much. So I really hope we're bringing even more value week in, week out. And I can imagine we're going to take some of these conditions going forwards and jump in down the rabbit hole even further.
Yes.
But today is all about low back pain and tackling pain. So whilst we're going to focus on the low back region, the lumbar region, we are going to make reference to, say, the
pain
thoracic spine, the C-spine, cervical spine in the neck, and just pain in general.
Yeah.
Go from there.
And I think everybody knows somebody that either has or has had back pain.
Yes. Well, I know you've experienced.
I get back pain.
You get back pain, but you've experienced it on quite an acute level. Yeah. Whereas, say, I've experienced it on not as harsh at any one point, but for longer bouts, I'd say. Yes. At times.
Yeah, absolutely.
So we all know somebody that's had back pain, or we've experienced it ourselves.
Yeah, totally.
Now, before we do jump into this, where was you going to go?
I was just going to say about the different types of pain, really, and back pain.
Well, I was going to go into, first and foremost, say, back pain, I think, is considered, because so many people do experience it, and I think it's going to be, and it is it's a common clinical condition.
It is.
Okay, and it's going to be common within clients. I think back pain kind of gets pushed to the back seat. No pun intended. Of like, well, you've got back pain. Everybody has back pain. I can deal with that, or I can work with that. Let's strengthen up the back, or you need to work on your core, or you need to move a little bit more. You need to strengthen up your glutes. Whereas I want to kind of like just put a bit of a stamp on this episode right out the gate and say, back pain is incredibly serious, and it's not. And I don't think it should be seen as a condition that, well, everyone has back pain. It's all right. Just crack on. We can deal with that. Okay, or we could associate that pain came from muscle soreness, or I did my deadlift wrong, or
from trimming the garden
or
in
from
the wrong
trimming
way,
the garden.
or...
I think I really hope this episode, my intention for this episode is to dispel that and for you to leave and go, do you know what?
Nice.
Back pain is actually quite a serious condition.
Yeah.
And as a fit pro, I have an awful lot of responsibility to manage my clients' back pain.
Yeah. Well, low back pain itself is classed as being any pain, tension or numbness between the bottom of the thoracic, so all of the lumbar vertebra.
So L1 down to L5.
Yeah, the sacrum, and right down to under the gluteal fold, which is the the pronounced bit under your bum, basically.
Your butt. So the saddle. So
it includes all of
your
that.
buttocks. Yeah, well, what you're sitting on completely.
Yeah. So that's anything in that zone is classed as low back pain.
Cool. So as we go through this, we're going to be talking about a lot about posture and about the physical abnormalities, I suppose, of the body. The causes. But I want to kickstart, and I also want to talk about the kind of like what's going on between the right ear and left ear, and our understanding of what pain is as we go through it. So the psychological aspect of back pain.
And I think that's wildly appropriate, even beyond back pain.
Yes, completely.
Any pain.
Yeah, any pain. But as we go into this, we've first and foremost got to understand what is pain. So I want you to, obviously joining with our conversation as you listen, but for you to just take a second and think, well, what does pain mean for you? So I'm going to ask you, Hayley, what does pain mean for you?
Pain for me is something that is uncomfortable. It's something that at times can be unbearable.
Yeah.
And I think also something that comes up a long time is if you think about having pain for a long period of time, and that is relentless and doesn't stop. For me, that airs on torture. Like, that's what torture is. Like, pain that doesn't stop, that just keeps going. I'm not very good with pain. Like, I don't have a good pain threshold. Like, one little bingo pinch and I can cry. So, like...
Hayley will stub her toe and, like, be on the floor, almost on the verge of, like, self-torture.
So pain for me is like, oh, that's painful. Could be something that to someone else was quite small.
Completely. Whereas, and I like what you used there, like in terms of like pain threshold. I'd say my pain threshold, certainly having done a number of ultra runs, is a lot higher.
Yeah.
I am willing to endure and sacrifice an element of pain and discomfort, knowing that there's an outcome.
Yes.
And I think the more I've exposed myself to uncomfortable, and I'm going to say quite painful situations, you then build up this pain threshold where you go, well, that didn't hurt.
No. Yeah.
Yet to somebody else, that could hurt. So the first inquiry question could be, is somebody experiencing back... One person's back pain cannot be compared to another person's back pain.
Good point. There you go.
There you go.
That's
there it is. Yeah. So Hayley might get back pain, and I go, oh, what you're doing, don't talk about that. It doesn't matter. It wouldn't hurt me. My pain threshold's very different.
Yeah.
So again, like the back pain has this kind of, I'm going to say, taboo topic behind it of, well, what does pain mean for you and what's it associated to?
And then it gets dismissed easily.
Yeah, completely.
Yeah.
And so for me, pain is very much, I don't feel like it has to be something incredibly painful
for you to class
it as pain. Yeah, completely.
So you might class it as an ache, you might class it as uncomfort, discomfort, something doesn't feel right.
Whereas my discomfort could be like torture for you. And so something I like to do with clients when we're talking about pain is to have this 1 to 10, almost like an RPE scale, but a pain scale.
Yeah, pain scales can be really
powerful. So 1
powerful.
would be, 0, 1, 2 would be
it's okay.
It's okay, no pain at all the way up to, well, what is their perception of a 10?
What's their 10 out of 10? It's probably on par with the most they've ever experienced.
Yes.
If maybe that's breaking an arm, childbirth.
You've never broken a bone.
No.
So you're stubbing the toe is maybe one of the most painful things you've experienced. Yeah? Well, I've completely shattered my radial head.
Yeah.
Okay, and I remember the pain was unbearable. I chopped the end of my middle left finger off, cutting up lettuce, like fully chopped through
missing the end part of his finger.
and went completely severed the end of the artery. Like, that was painful.
Most I did
and
was
then
almost my little toe off.
And then the consultant, without any anaesthetic or whatever to help me relieve the pain, went along and touched the end of the artery of this open wound, and I completely passed out several times.
Remove their breakfasts.
No, but my point there is what is someone's 10, and can they give you...
I'd pass out way beyond that.
Yeah, you would have been gone. You would have been gone.
I've gone way before that.
The point is if you've experienced a level of trauma that you can associate that pain to...
Yeah.
Now you've got this 1 to 10 scale.
And the nice thing about that 1 to 10 scale, and also what you were saying about the different types of pain, is there's actually a couple of different types of pain straight away.
Yeah.
One's nocioceptive, which means it's coming from the receptor. So that receptor is like if you were to put your hand over a hot flame. This is what we learn about quite often in terms of the understanding nervous system. Hand over a hot flame, you can feel that on your sensors on your hands, your skin receptors.
So you get a afferent message back to the brain. The brain then deals with this threat or this pain, and then decides with what the action should be. So you now get an efferent message back to the various joints and muscles
to move it away,
to bring about movement
and to stop that pain from happening. Now, the nice thing about nocioceptive pain is you go, that hurt, like putting your hand on a flame or a foot on a drawing pin.
I won't do that again.
I will move my foot or my hand away from that pain source. Pain gone. Non-nocioceptive means that that's where that subjective thing of where people fit in that pain scale is different, because non-nocioceptive is it's not coming from a sensor. So this could be the nerve being squashed or interrupted or damaged,
impinged or squeezed,
or cut,
inhibited.
And that,
check us out with our dictionary today.
Woo! And that non-nocioceptive is confusing. It's like haywire message going back to the brain to say something's not right, but I don't know where it's coming from. Something's not right, but I'm not sure where it's coming from. And
so can I interject? So for example, I know you're on a flow here. So for example, you could be standing up, and for the body system to be all in, let's be really crude here and just say in good alignment, and there's no impingement of a nerve.
Yeah.
Yet you could bend over, and that movement could now impinge on a nerve, and all of a sudden alarm bells go and you've got a signal going back, but your body doesn't know
where that necessarily came from
or why.
All it gets is an on and off signal. So that on signal coming back up the afferent nerve is going, this has been targeted, which is why you get referred or radiating pain, which you can't locate where it's coming from, but you feel pain or tension in that area.
Something of discomfort.
And then the worst thing is, because there's no particular site that it's caused by, your brain might be sending back a thing of saying, move away from that area. I think that's the problem, even though it's not. So you end up moving and compensating, which causes more tensions, more problems in certain areas.
But you could also build up, I'm going to say, a belief that you went, okay, so I felt that discomfort when I was bending over, I was doing a deadlift, for example. I'm now not ever going to do deadlifts again.
100%, yes.
So you could associate that to the actual, the exercise or activity you're doing. That could be, for me, it would be gardening. No, it wouldn't. Do you know what I mean? Like, it's an easy excuse out of this one.
Yeah, it's the workout, it's the gardening, it's completely. The twisting funny, it's picking up the kids
So I'm going to call that fear avoidance.
Yes.
And we're going to talk about that shortly.
Yeah.
Yeah.
But they're kind of the main two different things about pain. And it's just nice to remember that you can't treat it the same as the type of pain where your hand's over a flame, because you can't move away from it. So there's that torture, that thing that continues.
What I like about pain, it sounds like that sounds really
I like pain.
That sounds really bad, doesn't it? Is that everyone is on that different sliding scale, and some pains can be associated to particular traumas. So for example, you could have been in a road traffic accident, and you could say that pain was attributed to
this specific whiplash caused this specific pain.
Yeah, completely. Like, it's not related to back pain, but a couple of years ago, I was on one of those aqua parks, and I was with clients.
Big inflatable aqua park.
Yeah, and I got caught between two obstacles, and there was various people and clients around me, and I got, for a better word, pulled apart. So I had one or two guys almost laying over my legs, a couple of other guys in the water pulling on my arms. And for those of you, if you're watching on YouTube, imagine kind of this kind of transverse kind of tension of my body being unraveled and dislocated my shoulder.
Just pulled you apart.
Yes, my shoulder dislocated and had some pretty bad damage to my rotator cuffs. So you could say, right, that event did cause
the causation.
The causation and associated to that pain.
But there's some other types of pain which that isn't necessarily the case, or we might think that it comes back to one physical thing, but actually it's not necessarily a physical cause to the pain.
Tell us more.
So there's this thing called TMS. And I know that you will help me with this, Neil.
Yes. So tension myositis syndrome.
There you go, thank you.
Tension myoneural syndrome.
Okay, cool.
Cool. So what we're talking about here is that there
like
is
physical tension in the body.
Yeah, there's tension in the body. There's a site of pain. So let's just say that my low back hurts, my left low back. Okay, and I can clearly go, I can put my hand on that and go, my back's incredibly painful today. It's sore.
It's tight, it's achy, it's crampy.
And you could, I suppose, make up a belief pattern and say it's because of work, or it's because of the way I moved, or I laid funny that night. Yet there's no pathological or physical root or inquiry to say your back hurts because.
Yes.
And so TMS is in fact, I'd probably divert you to go and read a book called The Great Pain Deception. I'll show it on screen just now.
Which is Steve Osnich.
And I'll put it in my show notes.
And the work that he's talking about is a guy called Dr. Sarno.
Yes.
Really, really interesting to see how he links the understanding of something more mental, more psychological to a physical pain that you may feel.
So we've created, for a better word, and we believe there to be a physical site of pain or discomfort, yet it doesn't matter how many MRIs or ultrasounds or clinical tests you do, there's nothing to be found to say, actually, I can see why you've got mechanical low back pain. I can see why that's playing up.
Yes.
And so Dr. Sarno's work, I suppose, if I wrapped it up crudely, would be we create an element of pain because it's easier to deal with back pain or neck pain or shoulder pain rather than deal with the deeper pain or the psychological pain that I suppose you were meant to be dealing with.
Which could be like grief, it could be relationship problems, it could be
trauma, it could be a whole host of other reasons why you're experiencing discomfort or pain
it's really
mentally. And rather than deal with that, jumping in, you I suppose manifest a physical symptom, yet there's no pathological root to that physical symptom.
Well, it's if somebody asks you, someone you know a little bit, and they go, how are you feeling today? It's easy to say, oh, my back pain's getting me down a bit.
Yeah, completely.
Than to say, at the moment, I'm heavily in the middle of a load of grief.
Yes.
Like over somebody I've lost.
Or whatever that trauma
it is.
Yeah. And again, I want to kind of sit on the fence and say everyone's different.
And that could, again, comparatively be something that one person might think is very small.
Yeah.
Another person might be massively affected.
Yeah. And that's why I think when you're dealing with low back pain, yes, the back pain could be real. And even with Dr. Sarno's work, actually, the symptoms and the feelings and the way we move presents everything that the pain is actually real.
Yeah. It's still about messages.
It's still about
messages.
But I think the point here is, I talked about on previous podcasts, FitPro sessions we've done, that clients could have mindset sessions, or I class as head sessions. So, on a regular basis, once a month, you could sit down with your clients, or however many times needed, because an individual, have a cup of tea, a cup of coffee, and find out exactly what's going on in their world from a mindset, mental perspective. Because the amount of research that correlates low back pain with mental health, such as PTSD, anxiety, depression.
Massive links. There's even links in the medications used. It's really
completely, yeah. So the medications that actually help
with back pain, quite often are things like amitriptyline, which is an antidepressant. So that there's this combination.
There's a correlation there.
Correlation, not combination.
Our dictionary is slowly declining.
As the voice gets
voice goes. So that's. I think it's incredibly important to consider that. Yes, we want to get clients moving. Yes, we want to tackle their pain.
Yeah.
But I think the majority of the wins to be had are going to be from a mindset, communication, inquiry.
Well, there's a lot of studies that have gone into looking at the difference between treating somebody for any pain, but most particular back pain we're talking about today, the difference of using what we call a biopsychosocial model, which combines biological, i.e. looking at posture and strength and flexibility and range of movement, and even surgery if needed. Then also combine that with the psychological side of treatment and a social side of treatment. So you're using a mixture of all three rather than just going, right, the solution to your pain is you need to have an operation.
Yeah.
So there is this, because even with the operation, if there's still a psychological and a social issue, that doesn't get combated, the pain will shift to somewhere else.
Exactly, which is what Dr. Sano is actually talking about.
Exactly.
So you could go and have, I've had clients where they've gone and they've had surgery, either before they've got to me or during they've been with me, and then the pain is, for a better word, just moved to another joint.
Yeah, literally creeps around the body.
Completely.
And so if you're not going to pay attention here, I will move to somewhere else. And
I think before we go down that biopsychosocial model, let's talk about specific and non-specific back pain, because we've mentioned it and alluded to it, but I think it would be worthwhile having a definition and then talk about the prevalence as well before we go into get fully down the rabbit hole.
Yeah. So in terms of prevalence, about a third of the UK population will have back pain in any 1 year is anticipated.
So that's like 23 million people.
Wow.
That's quite, let's just stay with that. That's a huge pool of people. And I've suddenly got really excited over somebody else's pain. But I do get a lot of pain and discomfort in various joints. Down to running, I believe. But maybe that's all in my head, I don't know. But anyway, let's stay with it. You ready? You're laughing, I get it. But let's just say that you were going to focus and become a back pain specialist, or you were going to be the FitPro that went, do you know what, I've done Pilates or yoga, I'm a personal trainer, and I've experienced pain myself, and I would really like to help people manage their pain either by physical movement, either by increasing someone's NEAT, tackling their weight loss or whatever, or from a mindset perspective. You're talking about 20 plus million people in any 1 year.
Also, that's 1 in 3. So one in three people in your gym will have back pain at some point in that year.
But if you had a lake, it's kind of like a lake, and imagine there's 70 million fish in this lake. Nice. Okay, yet 23 million of those fish, had back pain. It's quite easy to go fishing, and you could pretty much guarantee.
At the thought of a fish with back pain.
Okay, you could
instead
almost...
of bait, you're throwing out medications. I'd proof it out.
Too right. Instead of a worm, it would be an NSAID on the other end. Wicked. But you get my point, right? If you're going to go fishing for a client, at least make the pool of people you're fishing from a pool where you can go, do you know what? There's a lot in this pool. Yeah. Whereas we talk about this, and I know it's maybe not relevant, 100% relevant now, but if you've got, say, 70 million people in the UK that you could go and fish from, and you're after, I don't know, for example, back pain in tiddlywink players, you've now niched down so much so you're like, well, actually, out of this 70 million, I've only got 100 people to go and fish for. Likelihood of picking those 100 tiddlywink fish back pain little creatures swimming around is pretty tough to.
But you could choose mums with back pain, and now you've still got a really big pool, but you're still niched down to one particular problem.
Yes.
Or people with guys that have physical laborious jobs and back pain.
Exactly.
Yeah.
Yes.
Okay. Cool.
And that's what I like about I suppose the overall global term of just pain.
Yeah.
Cool.
So that's a third that they anticipate to have back pain.
Yeah.
But actually only a fifth of people go to the doctor and actually get diagnosed. So there's this kind of gap between the fact that they experience back pain but might not think that it's ever bad enough to go to the doctor.
Yeah.
So you might be sat in your first consultation with a client that appears perfectly fine, and they just throw in the words, oh, and I've had back pain for the last few months, but I've not gone to my GP about it because I didn't think it was bad enough.
Yes.
So you've also got this level that you kind of go, they still experience it. Just because they didn't think it was worth going to the GP doesn't mean that it's not something you need to consider.
Yes.
There are risks still involved.
Yeah, and that doesn't mean that person doesn't have a serious low back pain mechanical condition, or whether it is from a mindset psychological issue.
Exactly.
Now, I'm going to go on a bit of a tangent here and slightly off track from our notes.
Cool.
And talk about do you think there's a difference between male and females in terms of, and this is only our only opinions, around how they would deal with pain or whether or not they would go to a GP?
I don't know if it's necessarily male or female, but I think there's differences in people. Differences in people.
It could be differences in...
What were you thinking?
Well, I've got a client.
What's your guesstimate?
So I've got a client at the moment. I won't give too much information away, but let me tell you a little story very quickly. The guy hurt his finger, okay, at work, okay, and it turns out that this is quite a serious injury.
Right.
Okay, so he caught a bit of wood or a tile, and basically it impaled part of his finger, and he can pretty much say it's touching something inside. So in different angles when he's driving or changing gear or moving around the house, it literally says it brings him almost to his knees and in tears.
Oh, wow.
So I said to him, you know, you're going to go and get this sorted? And he's like, oh, no, I'm a big boy now, I can sort this out. And it was that macho approach.
Yes, I see where you're going.
I'm like, hold on a minute. Like, this is bringing you to your knees on you're almost in tears. We are 3 weeks in now. And I was like, what have you done? He goes, well, at the moment, I've got some tissue wrapped around it with some sellotape holding it on.
Oh, wow.
And I was like, okay, that's really interesting. So it's really made me think, you know.
Well, I was going to say, but I think you could have the same example of a mum that is so busy running around after her kids, picking them up, that they just assume that the back pain will go away when the kids get a bit bigger and they don't have to pick up the toys off the floor anymore.
Potentially, yeah, completely.
And not go to the GP.
Maybe it's a generational thing, completely. But I think from you know, having worked with a lot of guys, I get the feeling that guys are more likely to like shrug it off and go, it'll go in a couple of days. I'll be fine. I'm a big lad now.
Yeah.
Whereas I think ladies,
maybe that's not wanting to show that vulnerability of it.
Maybe that's the point. Yeah, completely. Whereas ladies are maybe they still don't go to the GP, but maybe they talk to their other mum friends about their back pain,
or take some medication just to limit it, like self-medicated.
Yeah, completely.
Yeah. Okay, that's interesting.
Yeah.
I like that.
Off on a bit of a tangent.
Yeah, I like that. Okay. Well, we were also talking about the difference between specific and non-specific back pain. So specific is where there is a specific cause. Now, this is usually structural specific cause that they can put either a date event stamp line on it and go, that's when they got that injury, that's that car accident you had, that was this particular
My back pain occurred on the 10th of August because a car ran into the back of me.
And that you can then see evidence of that on an MRI or an X-ray, right? So that's what that would show. But only 20% of all back pain cases are specific.
So hold on, let's go back. So we're saying 23 million people a year experience some form of back pain, of which 1 in 5 of those 20 million,
yes,
okay, which is 4 million.
I'm glad you're good with
maths. Only get diagnosed, of which only 20% of those 4 million, so we're talking 800,000-ish, don't quote me on these maths, okay, are due to something structural or something we can associate a specific cause to.
Yes.
Wow.
Yeah. So there's the specific cause. The other 80% of back pain has no definitive causation, which is classed as non-specific back pain. This links massively to what Neil was saying about what pain was in terms of TMS, and it may be coming from something else. It might come from just muscular cramps and tightness, which you wouldn't see on an MRI or an X-ray. So they look on the MRI and X-ray and they go, there's nothing there. And they're like, but I still have back pain. I can still feel it. Oh, well, it's non-specific then. What
I've really enjoyed doing is sitting down with a client and really ascertaining an average day. Okay, so and how you move in that average day. So for example, it might be, so when I get up, okay, so the first question is, how do you generally wake up, or how are you lying in bed? So I might go, well, I'm always on my left-hand side.
Yeah.
And you go, okay, cool. Now let's take us through the entire day, almost timestamp every 15 minutes to really ascertain what they're doing and how they're moving.
Yeah.
And then you find out that they're always sitting on their left-hand side. They're always doing something, twisting their left. Yeah. they're on the phone with their left hand. They change gear with their left hand in the car. There's lots of things
It's like this, yeah.
So you can't turn around and go, I think your back pain is due to X, Y, and Z. But what you could look at is an average day of their life and say,
a lifestyle accumulation.
A lifestyle accumulation is you are very biased towards this type of movement, and therefore your joints are acting and your muscles are reacting in this way.
Which could be a reason why you're getting this pain.
Which could be a reason why you're getting this pain. Which then allows us to have this discussion of, we're never going to say as a FitPro that you've got lordosis or kyphosis or scoliosis, or to almost diagnose a specific, what's the word I'm looking for? Postural compensation. We're just going to say, your lifestyle, your joints are acting like this based on lifestyle, based on your day, and your muscles are reacting like this, and therefore we could make some assumptions that this is the cause of that.
Yeah, and as a result we could do these types of stretches, we could activate these types of muscles, we could encourage you to sit a different way at work, we could encourage you to set up your chair slightly differently at work. All these different things that start to become part of that biopsychosocial.
What I love about what you've put in the level 4 low back pain qualification, for example, and we touch on this at exercise referral as well, is and certainly at level 3 PT.
Yeah.
We did it for the weekend, in fact, is SOAP. So the acronym of SOAP. So doing all of the subjective assessments.
Nice, okay, which is the
talking, the questionnaires, the pain scale, the average day of your life, time stamping.
Yeah.
And then you've got the next one down.
Objective.
Get my words out. So I couldn't spell.
We all do it.
Okay. Objective assessments where you could perhaps do
physically measure something.
Yeah, physically measure. So an example of that would be waist and hip circumference, but in regards to back pain might be a range of movement test.
Yeah, or it could be the strength they have in one leg compared to another,
or a flexibility test completely. And then you can make an assessment of what's going on subjectively, objectively in relation to their goals, okay, and then make a plan. And that plan could be, well, this is what we can do for mobility, this is what we can do for activation, this is what we can do in our warm-ups, this is what we're going to do in our 4 or 8 weeks of working together.
And
this
it could
is
be as simple as, because you've
achievements.
seen that maybe they've got limited range of movement, you just spend longer in your warm-up. That could literally be it. You go, I'm going to have a longer warm-up, getting really nice and toasty warm around that joint, and I'm going to do more mobility and more dynamic stretches to work into that area and just see if it makes a difference overall.
I like that. So we've done specific and non-specific. You've done nocioceptive and non-nocioceptive.
We've
talked about TMS, and we've talked about kind of the psychological aspect of what pain is, and then we've looked at what physical pain is.
There's some time frames as well. Do you want to talk about the time frames?
Yeah, go for it.
Okay, just quickly. So there's 3 different sort of bouts of time frames, and these are acute low back pain is classed as anything 6 months. Oh no, chronic is classed as anything that is 6 months onwards.
Yeah.
So that means it's chronic, it's long lasting, and it also accounts for anything that's reoccurring. Then a subacute is anything between 12 weeks and 6 months.
Okay.
So you kind of got that middle ground, and then the acute is whereby it lasts only up to 12 weeks.
So that could be literally 1 day all the way up to 12 weeks.
Yeah. Could be 6 weeks. And that's why quite often a GP recommendation with back pain is go home and rest. Let me know how you feel in 6 weeks. Come back. Let me know how you feel. If it's still carrying on after you've done implementation of walking, resting and taking this medication, then it might be something more serious.
Which is, again, leads us down another kind of... What I love about this episode so far is like lots of different avenues down this rabbit hole where we've just kind of like jump down the rabbit hole,
dip in a little bit,
come back out and go down the main rabbit hole. Yeah. But what I like about that is the wording that I think holds us and sabotages our space around pain. So if a GP said to me, and this isn't a derogatory comment towards GPs, okay, and it's part of the biopsychosocial model as well, around faulty beliefs. If I've got acute pain, so you've got acute, subacute and chronic, and I'm saying, right, Neil, you've got to go home and rest, okay? Take these ibuprofen, rest up, don't do anything that's going to agitate it.
Yes.
So now my belief is that I'm going to change or stop my physical activity. I'm no longer going to do things like wash the car, do the gardening, where I bring about NEAT, so non-exercise activity thermogenesis. So now I've become maybe more inactive, more sedentary.
And also because that would hurt. Like, anyway, some of those things could really hurt.
It could do, yeah, completely.
Or you're just scared of it.
But that's the point, would be fear avoidance.
Yeah.
But we also need to have a consideration that actually moving in a very smart and effective way is actually going to benefit this person way more every time than not moving at all.
Especially if we speak about range of movement, just in that last bit we were talking about with posture, and how just increasing range of movement and allowing movement to happen.
Certainly if it's non-specific as well.
Yes.
Like if you can't specifically say that's why your back's hurting, then you can't attribute that to a particular timestamp or an event or a particular movement. So actually the best thing to be doing is to continue moving within the parameters of how you can move.
Yes.
Yet the belief could be go home and rest, don't do anything.
Yeah.
Which from my experience working with clients is a big fear avoidance to get past, because the moment you say, right, we're going to get moving again, would be like, hold on a minute, I don't want to make this back pain any worse. It's already bad.
Yeah.
Moving, and now it's a converting of mindset, and it comes back to, again, a behavioral change issue with the client and getting rid of fear avoidance and understanding what pain means.
Because it's not just one thing that will help them come out of the back pain.
Completely.
It is that mixture of everything.
Yeah.
Yeah, definitely. I think that was a nice little rabbit hole to go down.
Let's come back out that little rabbit hole and down the main one. Where are we going next? Where are we now on our plan?
I wanted to talk about the serious side of back pain.
Wicked, yes.
So obviously back pain is serious anyway, but there is a very, very serious part of back pain which relates to how we screen with our clients. And there's a certain amount of screening in terms of what data we take from our clients. If we notice a certain few things happening, it could be an emergency.
So this would come up on consultation 1, for example.
Where you're talking about the subjective stuff.
Which is subjective, where you're basically building up know, like and trust and building up rapport and finding out you're a fact checker. Yeah, completely.
And these are red flags we're looking for.
Cool.
So red flags basically mean if you've got a client that's got 2 or more red flags, one of them's back pain, so, got to have 2 or more red flags, then at that point,
can't work with you.
You would refer them straight to the GP. And that's because they start to link towards a condition called Cauda equina. Now, Cauda equina is rare, but an absolute emergency because it can lead to paralysis and also total numbness, total paralysis from the waist down, usually.
Yeah. What was really scary, let's go back about a year. I was with an osteopath and I had 4 of these red flags. And they phoned up Derriford Hospital down here in Plymouth and they said, I've got a client on the table right now that's got 4 red flags.
I won't work with him.
Can
I send him for an MRI?
And you know what they turned around and said? We'll get him on the waiting list. I didn't have.
You did have an MRI after, didn't you?
I did have it pretty quick.
But they done it on the wrong part of the spine and you ended up with just your neck and head done. Oh, okay. But either way,
I digress.
Those flags aren't there now.
Yes.
So these red flags that you need to be mindful of. One is back pain. So let's get that one done.
Yeah.
The next is gait disturbances. What are you doing?
Yeah, there you go. You carry on.
Next is gait disturbances, which means that when they're walking, there's a shifting that occurs or a changes to how one leg might be going further forward than the other. So gait disturbances. The other part of this is radiating pain down one or both legs. That also leads to weakness in one or both legs.
Yeah.
And numbness of the saddle area,
yeah.
Which if you imagine sitting on a saddle of a bike, it's all of the undercarriage that touches that saddle. That's the bit that's numb.
So that could also lead to things like going to the toilet unexpectedly.
Yes, so bladder and bowel dysfunction is also that. And that could be constipation or going too quickly.
Yeah.
But these red flags are really important to just listen to with your client. So I had a lady come and work with me. This was a lot of years ago. But she came and worked with me and she had back pain. And as soon as she walked in, I was like, gosh, she walks very bizarrely. She sat down, had trouble sitting down. We went through some of the stuff and I asked her some of these questions. She's like, oh yeah, I always have problems with with bladder. She's a little bit older anyway. I always have problems with bladder. Every time I sort of stand up, and I'm like, okay, cool. And she's like, and she does get pain. And I was like, okay, these are lots of red flags. And I asked her, when did your bladder dysfunction start? Was this in line with the same time frame as your back pain?
Was it?
It actually wasn't.
Okay.
And it turns out that it wasn't anything to worry about long term, but it's a really nice differentiating moment, because is it just that she's got problems with her pelvic floor, she's a little bit older, that she's that she's got these issues here, or is it that she's having bladder and bowel dysfunction as a result of whatever's causing the pain?
I think that's where the knowledge and confidence, you've just hit the nail on the head for me, because you could not literally you could be sitting in a consultation, or you could be meeting the client for the first couple of times, and it's through your world-class open questions and your ability to reframe questions and go deeper, what I class as 3 or 5 or 7 questions deep. Yeah. So you ask the surface level question, they give you a surface level answer, you go deeper on that to find out the facts. And I think that's where the knowledge comes down to, because you go, well, every client's different. They're always going to answer me in a slightly different way, but I must find out the facts around these red flags, specifically towards low back pain or any condition really. And I can't just make the assumption of because you've got low back pain, you're good to go. It's my job as a FitPro to become knowledgeable and say, right, I want to help a client. I want to get them towards their goal, but I must find out everything about them to tick off and say, no red flags, I'm good to go.
Yes.
And it's through that knowledge and world-class questioning and through that subjective consultation 1 or 2 that allows me to move forwards.
And I think timing of those symptoms is a good differentiator. Yeah. Really, really key.
So you mentioned red flags. We've also got something called yellow flags.
Yes. Yellow flags are all psychological and social.
Yeah.
So we've kind of had like the structural side of things with the red flags. Once you know there's no red flags, you dive into the yellow flags, and this means that you're starting to show that there is a psychological and a social connection to how your client experiences back pain.
Which again does come back to Dr. Sana's work and TMS. So for example,
really does.
One of those things could be linked towards work, which would come under the biopsychosocial model. Is that correct?
Yes, so, all of this is
so for example, you might be having, the client might be having a really rough time at work with high levels of stress, okay?
And then by having time off work
because
with
of back pain allows them to alleviate the real problem of they can't handle the demand of work.
Now, what's really key here is we're not saying they're not experiencing back pain.
Yeah, completely.
We're not telling them that they're lying.
No.
And we're saying that they've got this back pain.
Exactly.
Which, in having back pain and it being diagnosed and the doctor saying, yep, go and take some time off work, it allows them to separate themselves from something that's happened at work.
Completely. Which goes back to what TMS was having no pathological or definitive cause. So we've got work. Another one on my notes would be, for example, perhaps they've been in maybe there is even specific back pain here. And you could say, right, there was a road traffic accident, but the back pain is lasting longer than it perhaps should do or could do. And from a compensation perspective, they are expected to get a financial compensation.
Okay, yeah. So they're waiting for this compensation
come through, and it's the amount of stuff I've read around this. It's amazing how many people's back pain doesn't disappear overnight, but disappears soon after the compensation claim has been made.
Also, that's quite stressful on the body, which builds up tension. So that links in with the TMS side of things
completely.
Again.
So the tension is held within a joint or region of the body until the stress or tension has been dealt with.
Yeah.
Completely.
The other thing is that beliefs that they might hold in relation to how they get treated. So they might have what we call an external locus of control, whereby
this is nice. I like
really
this.
believe that you can only get better if you have surgery.
Yes.
They wouldn't believe it comes down to or that they take pills. They wouldn't believe it comes down to them getting up, going for a walk, and stretching.
It can't be as simple as a morning 15-minute yoga routine.
Yeah, they're blaming someone else for the fact they're still in pain. They're blaming a treatment process that is outside of them.
Yeah.
Yeah, that really comes into it. That's that external locus of control. Also their attitudes and beliefs around how they're coping, so their coping mechanism.
Yeah.
So the coping mechanism might be that they, let's say, use heat packs on their back and have medications. Now, if they have a relationship with family member that is overbearing and is constantly going, oh, I'll change the heat pack for you. Here's some more medication. No, don't get up.
They're getting a lot
I'll
of
get
their
it.
needs met.
Oh, a lot.
So
yeah?
you're getting
A lot
growth,
of
you're getting
attention.
contribution, you're getting significance, you're going to get uncertainty. So Tony Robbins talks about 6 human needs. We won't go into those now, but once you've got 3 or more of these 6 human needs met,
You're addicted.
And so another family member could actually, for a better word, keep you within a place of pain because you're getting more of your needs met. And likewise, the antithesis to that is you're not getting any focus from family members or loved ones or relatives or friends or work colleagues. And no one's saying, Hayley, how's your back pain today? And so you manifest it to be way worse than it was or is.
Yes.
Does that make sense?
Yeah, exactly.
Cool.
Yeah, so that reaching out for help.
So the red flags would be something that you really need to focus on. Yellow flags, obviously, you need to focus on, but it's more of a biopsychosocial element.
They're psychosocial. So the more of these that you have build up, the more indication that you can have that the pain they have is non-specific.
Yes.
So with the red flags, you're thinking it's more specific probably. There's an issue.
Cool.
Yellow flags, you're linking that more to being non-specific, and as a result, you want your treatment process as you're working with them to use that biopsychosocial model whereby you can go, I'm going to work on your posture and things, I'm going to work on you psychologically, and I'm also going to work on how you interact with work colleagues and
Completely,
relationships.
because one of them could be under that yellow flags, could be around emotions and talking about, you know, the link with depression and anxiety. So again, you could take the timestamps of every 15 minutes of a day, figure out what they're doing, how they react emotionally to the day,
and how they feel,
and figure out actually their nutrition really doesn't serve them. Their current level of need is really low, and if I had somebody standing outside the door right now where we're recording and they were depressed, it would be of no surprise that they'd be slouched, their posture wouldn't serve them, they'd be really, chest shallow breathers, they would be apathetic, they would pretend lethargic, looking down, there'd be like loss of appetite.
Sitting on the sofa curled up.
Whereas, immediately I can change some of those, hopefully, and challenge them over a period of, say, even just a couple of weeks, changing their physiology almost immediately. But over 4 to 8 weeks, you could radically change their world, and therefore you could change their emotional state, and therefore change their yellow flag or their current score of their yellow flag.
Yeah,
if
really
that makes
fascinating.
sense.
Yeah,
cool. Let's go with the red flag and look at, say, because this is what the level 4 does, the level 4 low back pain.
Yes.
It does jump into a number of specific causations. So we won't go into all of them, but
no.
I did task Hayley with a job to
There's
pick
a
up
lot
on
of
a
long
couple,
words on these, so
which is why I'm not going to say them.
things like spondylitis, spondylosis. We're going to dive into a few that are probably the more common of them. Now, these really do require somebody that knows what they're doing in terms of qualification with this.
Yeah.
So that's why we embed them into the level 4 low back pain qualification. But spondylosis is the first one I want to speak to you about. Spondylosis.
Cool.
Anything with spondy at the beginning relates to the spine. The losis in this is relating to osteoarthritis, basically, of the spine.
Cool.
So if you imagine the discs in between the vertebra, that's the one.
Here we go.
The intervertebral discs.
I am of use.
As we get older, or depending on how restful we are in our day, over time, these can dehydrate.
The discs in between, yeah.
That's it, sorry. The discs dehydrate, which means that the vertebrae get close together, there's less cushioning between it, there becomes more wear and tear between the bones. Now, as a result of this, just like with arthritis of the knee or any other joints in the hand,
it's bone versus
bone starts to wear down a little bit, and this can cause not only you've got that narrowing the discs already happened, but now you've got little bony spurs starting to appear. Now, these bony spurs are essentially little nodules. And these can be incredibly painful because they can restrict movement. So if you imagine your knuckles together, that restricts the movement compared to a smooth surface together.
Cool. So the bone articulating almost like, dare I say, like concave convex, where it's a nice smooth articulate surface where it can roll around. Whereas now I like that.
Bony spurs, interlocking.
Interlocking spurs.
Isn't that geography?
It is geography.
Got a little blast back to A-level geography then.
We do like to cover all aspects of FitPro sessions.
Wait for the C defences.
Let's stay on track with spondylosis. Is that what it was?
Spondylosis.
Spondylosis.
And the treatment for this is often going in and actually they shave off parts of these bony spurs.
That sounds pretty painful.
But actually it's quite it's microscopic. So they can literally go in. Yeah, and therefore it's not very interfering. So they can go in, they can just shave off these bits that are rubbing, which will free up range of movement instantly, which will have an effect on the muscles around the
what I
spine.
like about this approach now, it becomes a multidisciplinary approach, because obviously you're not going to do this surgery. However,
unless we have a surgeon listening.
Yeah, but you will be part of a multidisciplinary team. So once they've had this surgery, there'll be some element of initial rehab with physiotherapy maybe, or physio, and then they're going to come back to you. So you're still firmly in the trenches with them, either after this, perhaps they've gone through this on their own and now they've been referred to you after, or they've been your client and they've gone off and now they're coming back. But ultimately, it's a multidisciplinary approach, and the role of a FitPro at this stage is incredible, because you're going to improve their quality of life. You're going to advise them around mindset, nutrition, and movement and rest. Well, that's what FitPro is. It's a difference in work and rest, isn't it? Yeah. And lifestyle, but you're going to have a huge impact on their life ongoing. Whereas the other members of this multidisciplinary team, they come in, they do the surgeon comes in for probably just 20 minutes and he's off again, and the physio nurses come in or whatever.
6 weeks.
6 weeks. Now you're the kind of, dare I say, the mainstayer. You're the one there long term in the trenches, making sure this person's quality of life only ever gets maintained or better.
And builds back up. So that's spondylosis.
Cool, next one.
I think I do spinal stenosis next.
Spinal stenosis.
Spinal stenosis is essentially, if you think about the spinal canal where your vertebral column, your spinal cord goes through, that spinal canal starts to reduce. So it's a narrowing of the spinal canal. Now, that could be from any number of different reasons. Usually it's inflammation of the ligament that flows through there, or of any other soft tissue around it, or connective tissue. It also could be down to obstruction, so either the facet joints or bony spurs we were just talking about, or even a disc herniation going into that area. Now, the big problem here is if you've got a nerve that is super, super important, super, super sensitive, like our spinal cord, and that you've got things starting to encroach on that space. Or sciatic nerve. Yes, starting to encroach on that space. At that point, they start to get that non-nocioceptive pain, whereby you don't know where it's come from, but there is pain. That's radiating, it's shooting.
It's like a dodgy light that goes on and off, but the switch is always on. Yeah, completely. What I really like about what Hayley just said actually is it's a FitPro, has to have at this stage a very good, thorough understanding of the spine, but not just say, right, that's my L1, is to understand, or my lumbar vertebra, is to understand that every lumbar vertebra is maybe slightly bigger and it has bony landmarks that I must know, and see each vertebra as a map, and just like a map of, I don't know, we live down in Plymouth, so a map of Plymouth has different locations. Okay, so you've got the seafront, you've got the town centre, then you've got, different roads, different churches and whatnot.
The train station. The malls.
Every bone in our body is a map and has different locations, and each part of that, every square millimetre of every bone has a very specific role to play in the body.
And when that's not working in its normal role, you get different pains.
So this leads down that inquiry route of every bone articulates with another bone above or below it, and therefore creates a joint. tendons, ligaments, muscles will cross bones to bring about movement.
Yes.
But ultimately, the range of movement at a joint, the joint acts, okay, and how a bone articulates with the bone above or below it creates an action of that joint, which now, therefore, muscles can now react to that joint.
Nice.
So a muscle can contract and lengthen, and as we know, muscles work in pairs, okay? But we must know as FitPro, certainly for understanding back pain, is really understanding, well, what happens at L1 and what are the bony landmarks and the architecture of L1, and how does that work with L2? And what's the relationship between those two? What crosses that joint? What range of movement happens in that joint? What plane of movement do these muscles work in? What joint, or what happens at this joint, and what plane of movement or axis of movement happens here? Brings
it all back to why we learn anatomy and physiology.
And that's why we learn anatomy. And, I don't just throw it out for like, oh, that's overwhelming. Of course it's going to be overwhelming if you've not understood it or you don't know it.
Well, part of that,
but we
if
must
you think about what I was just saying about spinal stenosis, if you know that your client has the obstruction on spinal stenosis on the posterior side of their spine as they're looking at it, and then you get them to do flexion work, then that might cause more pressure, more stenosis, more narrowing based on the injury or the inflammation and the position that's caused.
Completely.
So then that changes the joint actions you require. And then you're like, oh, that's why they feel comfortable when they're leaning on a shopping trolley and they're slightly tilted from the pelvis.
And they've got
but
an
when
anterior.
their body weight is shifted back, they feel the pain massively. And you're like, oh, I can start to piece together why they're responding in certain ways, why they feel comfortable in certain situations, why their muscles relax, when their muscles are lengthened, how it all acts together.
I like to use the analogy. Yeah, you did. I like to use the thing of like, the body is like water running downhill. Water running downhill will always find its least path of resistance. And so the human body will find positions during its day for the least path of resistance to avoid discomfort and pain.
Yeah.
Which would explain why we curl up on the sofa at the end of a hard day's work in awkward positions.
We all have our favourite place on the office as well, don't they? Like one foot crossed over. Mine's my little toe tucked right underneath.
Completely. Why people lean on their hands, and why they cross their arms in a particular way. Why they cross their legs completely. So we always finding the least path of resistance posturally. Okay, and this is key to understand as a FitPro and again, this comes down to the first consultation 1 and 2, subjective and objective assessments. Subjectively, you're asking them a question on their 1 to 10 of pain, but how are they sitting?
Yeah.
When they talk about pain, do they change their posture and their position?
Yeah.
Versus when they're relaxed. And then on the objective, the actual movement assessments, the range of movement tests, what's actually going on at a joint. And I must become, as a FitPro, I'm going to say healthily obsessed with understanding what happens at each joint, what muscles cross those joints, and therefore it's only then, and where the pain is, can I bring about a sound and thorough and smart assessment to say, we're now going to do this type of warm-up with this type of main session. We're going to do these training systems with these principles. And dare I say, the very last thing to get programmed is the exercise. Yet
last thing.
It's for it's for most FitPros. It's for what exercise will work for the low back, or what exercise I'm going to strengthen. It's what I'm going to try and strengthen the glutes. Consider for 1 second that the glutes don't need strengthening for this particular, for any client.
Yes.
Just because they are weak. They how do we know?
Yeah, there you go. Exactly.
Does that make sense?
Exactly. So the point becomes about understanding the principle, putting the principle in place and doing what's best overall, not necessarily about finding the individual tactic.
Completely. Cool. So that's another little rabbit hole we've gone down.
Yeah.
We come back out. So you mentioned spondylosis,
Spondylosis and spinal stenosis.
Cool.
Do we talk about disc herniation as well?
Is that the slip disc thing?
Yeah.
Go for it.
I remember this so vividly.
Go for it.
I had a client and they were like, oh, I've got to be careful because I've got a slipped disc. And I was like, oh, that's interesting. What do you mean by slipped? out of interest. What do you mean? And she's like, I was like, could you draw it on this bit of paper? And she drew her her version of a spine, which was basically just little dots. But then she got to one vertebra, and instead of drawing it in line, she drew it totally out to the side. I was like, oh, that's interesting.
Yeah.
So she believed that the whole vertebral piece, so that whole vertebra had slipped out of place.
Yeah.
Other people believe that the whole intervertebral disc slips out of place.
Which comes back to the biopsychosocial model of a diagnosis and how the person has been told about their diagnosis. So it's not uncommon to use the words popped discs or cracked disc or slipped disc. But again, it comes down to a communication issue or an understanding of what those words mean. So if I say, slipped disc, I immediately think, well, I actually slipped over. We went down to the beach yesterday and I did slip over. So I think something has to slip and move from underneath me.
Yeah.
So therefore I think, well, if I've got a slipped disc, then one of my discs must have slipped and moved from underneath me.
Which sounds major.
Which comes down to the yellow flag of a biopsychosocial model and a psychological aspect of my disc has slipped, therefore it must be crazy bad. Therefore, that's why my back pain hurts.
I'm going to fall apart. I can't do anything.
Completely. And then we enter that fear avoidance and understanding of why my back pain hurts.
And the pain coping mechanisms.
Yeah, it doesn't slip anywhere.
Exactly. So disc herniation is not it slipping, but that's the common term used. So I want you to imagine your intervertebral disc. I'm struggling with that word today.
Yet you managed to say the word spondylosis.
Spondylosis and spondylosis.
Yeah, completely.
So I want you to put your hands together, like when you do that one potato, two potato song.
Okay, I'm not going to do it. I'm not going to go down that route.
So you basically put your hands above each other. But everyone knows what I mean, even if they're listening.
We do, completely.
One fist on top of the other fist. And I want you to imagine you've got a jam or a custard donut in the middle of that. Now, this donut is like our intervertebral discs.
Are we talking about donuts or potatoes?
Well, both. So you've got potatoes that are your vertebra, and the donuts sit in between as the discs.
So 1 potato donut, 2 potato donut,
yeah,
3 potato donut.
Yeah,
there we go.
Yeah. You got it. Okay, good. I'm glad you're on my way.
I wonder how many people are laughing walking to this, or how many people have just gone, I'm just going to switch these goons off.
Don't know who these are.
Either way, we're going to keep going.
So the donut is
jam or custard?
Custard today, I'm feeling.
Yeah.
So the donut is the intervertebral disc, and this is really, really reflective of what the intervertebral disc looks like, because you've got a firm bit around the outside, which is cartilaginous, and then in the inside you've got your nucleus pulposus, which is like the gooey custard bit. In reality, it's kind of the consistency of chewy phlegm. I'm sorry. I'm sorry.
Okay, cool.
But that's the consistency we're looking at, okay?
Just roast everybody out.
So I want you to imagine a donut in between your 1 potato, 2 potato hand. Now, if I lean forward on my fist, if I push my fist together at the front...
So we're talking about flexion
of the spine. I press down on the front of my donut. Now, you all know if you hold a donut and you squeeze too hard on one side...
All the custard goes out the back.
It flows out the back. Now, at this point, based on the structure and what our vertebrae look like, the back is where our spinal cord is.
Yep.
It's where that spinal canal I was just talking about. So it pushes this custard or jam out the back in towards the spinal canal. Two things might happen. It might just bulge out a little bit, which doesn't have much effect, but it can easily go back in. Or all the custard could come out and make a right mess. So if the custard's coming out making a right big mess all over our spinal cord, this debris sends haywire signals all over the place. Of course it's going to hurt. Every time you flex, more custard comes out.
Ouch.
Every time you flex, more donut pushes on your spinal cord. So every time you're doing that, you're going to feel the pain.
So that's
a disc herniation.
Cool.
It's a mess of a donut.
It's a mess of a donut. Now, what I really like about that is when you can describe something, I'm going to say of master's level, okay, in terms of education, and draw it with Crayola crayons, or describe it with food. I'm going to say that was an epic educational experience. And I think that is it's probably a little bit, I don't want it to sound arrogant or big-headed, but I genuinely believe that's what we do well here at Parallel, is we take very complex topics, break them down, have a giggle along the way, okay? But you're left knowing and going, okay, I get that. So the potato was vertebra number 1. Then I had a disc, which was a custard donut. And then the one underneath that, the potato, was my vertebra number 2, completely. And then if I squeeze down on one side of it, what happens to the custard? If I squeeze down on the other side, what happens to the custard? Okay.
And also you can have this the other way as well. So if you lean backwards, the custard would squirt forward. But we don't have a spinal cord in front of us, so we don't feel it in the same way.
Completely.
Which is why flexion, loaded, often has the most amount of pain associated to it because it's pushing it back towards the spinal cord.
But that's why we must know what happens at the joint. Like the vertebral body itself is a very unique shape.
Oh yes, well it's an irregular bone.
It's an irregular bone, completely. And so now what can happen at each vertebra body, you know, does it work in the sagittal plane, the frontal plane, the transverse plane? What muscles cross that? How long are those muscles? What do they do when the joint acts? The muscles react.
What ligaments stabilise?
Completely. Then if I come up into the thoracic, what changes? And actually you'll find that range of movement and different planes of motion, okay, and different axes become available to us in different parts of the spine, which rule in and out particular exercises. And then if you've got a red or a yellow flag, you're now ruling in and out different exercises or principles and tactics of training as well.
And people might compensate if they're trying to avoid using one area, they might compensate with another.
Completely.
Also, one of the treatments for disc herniations, ones that go in and tidy up. One is that it just will sort itself out over time.
They replace it with fried eggs rather than jam donuts.
Yeah. No, they concrete it together.
Okay.
So they just...
I don't know where this is going with
They fuse the two vertebrae.
Okay, cool.
So they just fuse the two vertebrae together with bone concrete.
And then that I had a client a couple of years ago actually in my 5am club that had actually had 3 of his vertebral bodies completely fused together. Yeah. And his range of movement through flexion and extension was radically reduced. Yeah. Yet there was no pain. Yeah. And so now that we led on to a whole host of other things we had to work with. That's a different topic.
And then he adjusts above and below that would move more, which might have more risk of spondylosis.
Exactly, that's where we went. Yeah, completely. So one thing we haven't jumped into is we've talked a little bit about medications, okay, and obviously exercise referral goes down that route of medications. I suppose the typical ones you're going to hear would be NSAIDs. Yeah. So what is an NSAID?
An NSAID, which is a non-steroidal anti-inflammatory drug.
AKA?
Ibuprofen.
Ibuprofen or Nurofen, which can be over-the-counter, self-medicated. You can adhere to the rules of the back of a packet, or you can not.
You should only use them for about 3 to 4 weeks, though.
There you go. So, you know, the amount of people that I think don't truly understand the protocol around NSAIDs.
And just keep popping them.
And maybe not at the right timings, underdose, overdose.
And also these have the role of reducing inflammation, which is great if your pain comes from an inflammation source.
Yeah, oh wow.
If it doesn't come from an inflammatory source, then you might be taking these thinking they're helping, but it might not actually relieve the pressure on the nerve that you're looking at.
But then some of these NSAIDs can assist in backing you up, and what I mean by that is not going for regular toilet stops. Now if you're constipated and you're backed up, you're more likely to have low back pain.
Yeah.
So you're damned if you're doing, you're damned if you don't. It's a true catch-22 situation. The next one down is your antidepressants, things like
amitriptyline.
Yep.
And these are, although they're antidepressants, they have a purpose whereby the correlation is that they help relieve back pain specifically, even though they're antidepressant. And that's because of the neural pathway and the relationship between the brain and the nerves. So that's what's happening, is that numbing effect and that change of that relationship. But they also, as a result, you've got to be careful of things like nausea, vomiting, dizziness, gastrointestinal disturbance. My belly rumbled as I said that.
Completely. So and they also can lead to things like unexplained weight loss as well.
Yes.
And then
dependency.
And now you go down the whole mental health cascade, which we're going to do an episode on, I believe, next week, which is next week's episode. But then if somebody is gaining weight, and go back to last week's episode, sorry, that was type 2 diabetes, the week before around gaining weight and metabolic syndrome, you're more likely to have low back pain because of the weight you're carrying. It would be of no surprise if somebody was, let's just say, I don't know, BMI 35 versus their lean counterpart at BMI 25, that person would be exposed to more wear and tear and stress on the joints.
Yes.
Their gravity and body weight alone is challenging their posture. The joints, the muscles reacting to the joints, pulling us into a compensation world, and therefore getting some kind of non-specific low back pain.
Yeah.
There we go.
The other one...
I just want to jump in. But it's not as simple as just lose weight. Because actually there's more to it now, because you're now linking two conditions together.
Yes.
Losing weight, yes, could impact low back pain, but what's going on with the low back pain and within the red, yellow flags, non-specific, specific, and all the other funky work.
You're big, lose weight, and that will sort it.
Yeah, completely, because
it's too multidimensional.
It's too much yeah, there we go. Cool.
The next one is an opioid-based medications, things like tramadol and oxycodone.
They sound pretty strong to me.
They do. Hallucinations come into this. The biggest part of the side effects to this one, although it's a very strong pain relief, is addiction. So this is literally, they suggest 3 to 4 weeks. After that point, they need to be looking at it as a short-term process only.
Do you know what I find really scary is I'm almost at a point of losing count of the amount of clients I've had that when I've said, what have you taken? And they say tramadol. And I say, okay, cool. Was that via the doctor? And they go, oh, no, my partner had tramadol for X, Y, and Z.
For back pain years ago.
And we've got some spare in the cupboard or left over. And they worked a treat for her or for him. And we've had family members do exactly the same. And you think, hold on a minute, you're taking a serious prescribed medication that was for somebody else, yet you're using it.
Which is narcotic.
Yeah, which you're now using as a way of self-medicating.
Yeah.
Cool.
Quite dangerous.
Which goes down another inquiry route of what's really going on. Cool.
And there's one more, well, there is loads more, but let's not do an entire load of them. Muscle relaxants. Now,
do you reckon it would be useful to do a FitPro session at the end of this? We've already got to do an additional one. I can't remember what that was on. We have got it written down. Comorbidities. Do you reckon it would be worthwhile doing one just on medications?
Maybe.
And just take
if you want that, let us know.
Let us know, yeah, completely.
Yeah, we could do that. But muscle relaxants, unlike the name suggests, don't actually relax your muscles.
Amazing.
So GP says this is a muscle relaxant. Go and use it. It's actually about the relationship between the brain and the spinal cord.
Oh, okay, cool.
And the nerves. So it has the effect of removing some sort of cramps and things like that. But a muscle relaxant doesn't actually relax the muscles.
And then we could go on to think about the amount of products available. Okay, on Amazon. If you typed in low back pain relief products, the amount of heat pads or
TENS machines,
or the massage guns, or just going for a massage, or there's thousands of different products.
Those stretchy things that hold you upside down.
A multi-million pound industry where people with back pain, if it's acute, it's under that immediate to 6 weeks, was it, or 12 weeks?
12 weeks.
12 weeks, and then subacute 12 weeks to 6 months, 6 months onwards for chronic. That will go through and try every type of product
treatment.
Under self-prescribed treatment under the sun, and yet all they need is for you to come along and do a very thorough SOAP assessment, so subjective objective assessment and plan, and put together a really smart, logical plan that tackles their specific individual needs
in a biopsychosocial way.
Completely.
So you've got the walking, the stretching, the being able to look at specific postural tightness, activations, but then looking at how they respond psychologically and
because
how they
you're going to
socially.
apply principles behind it, backed up by science, whereas all of these other treatment approaches that are little tactics, it doesn't solve the problem. And that's where you come in as a back pain specialist of solving the problem of pain, understanding pain, standing in the client's shoes and seeing life through their eyes and truly saying, I get this. I have huge amounts of empathy, huge amounts of sympathy. I've got backed up by knowledge. I know exactly what we're going to do based on X, Y, and Z, and we're going to go through this protocol and guarantee results from there. I know what I'd rather choose.
I know what I'd rather
and
choose.
I've had a huge amount of pain over the last number of months regarding running. And I've worked with a couple of therapists.
You've had massages, you've had chiropractic treatments.
Completely.
But you've also had the rest of it.
Completely. And I'm making huge headway. And it's phenomenal when you do go down that inquiry route and not just rely on little tactics along the way, but just, for a better word, sedate and massage the problem. Cool.
That's back pain.
I've enjoyed this one. I think we could do a whole season on just pain because I think it's it's
also
really...
one of the biggest reasons why somebody would end up working with FitPro, to move away from some sort of pain.
Yes, we're either moving towards pleasure or away from pain.
Yeah.
Okay. Whereas with back pain, there is something physical, whether or not that is from a pathology of physical abnormality or whether we perceive it to be there, it's still pain. So from a leverage point, from you guys listening, not only have you got a huge pool of fish with back pain, okay, but you also have the concept behind marketing of people are always moving away from pain and towards pleasure. In this case, there is actual pain. You couldn't ask for any more of a leverage point in a huge pool if you tried.
And by using that 1 to 10 scale of pain at the beginning, you might find that after even one session with you, they're starting to feel better. And that is something that will sell the next session and the next session.
And what's really interesting, if I look at some of I don't want to use them as like fitness influencers, but if you look at, say, certain people on Instagram and Facebook that have just dialed into pain, their following has grown rapidly because of that leverage point, because people are always moving away from pain and towards pleasure. Yeah. It's this case, they're doing both. They want to move away from back pain and towards a life of no pain, which is, you've literally got the both elements of marketing genius.
Oh, it's amazing.
I love it.
Yeah.
And when you look at, in that comparison to, say, people that don't have their message on point as a FitPro, or they don't fully target a particular type of avatar or person, then they don't have that, they don't grow rapidly like that, if that makes sense. Yes. So they're not able to call out from a marketplace who they work with.
Then work specifically with the strategies that will help them.
Yes, exactly.
I'm impressed with your DOVT.
My DOVT, which was delayed onset voice tiredness. I feel like I've done a good job.
Up.
Yeah, completely.
It held up.
So
with that, I would like you guys to send a photo of how you've been listening to this.
Yes.
Have you been out for a walk? Are you working out? Are you just at home cleaning?
Have you gone out and bought potatoes and doughnuts?
If you're at home cleaning, then I want a picture of your marigolds out.
No, let's not.
If you've got doughnuts with you, I want to see the pack of doughnuts.
Do people still clean with their marigolds on?
I don't know, I don't.
Whatever. We just want to hear that you're listening and tuning in. So
drop it in the inner circle.
Drop it in the inner circle. Drop it on your Instagram, Facebook stories. Let us know. And if you have enjoyed this one and you want to let us know your main takeaways, then you can email us at info@parallel-coaching.com. Address it to Neil and Hayley, FitPro Sessions, and that would be wicked. Yeah. And if you have got value and you haven't yet left us a 5-star review in iTunes, I don't think you can do it on Spotify or the other ones. Unless it's changed. It would be wicked, because the more people we can reach, the more people we can help educate and bring our crazy little tactics of making complicated topics, make them really, really simple. And that's our passion, that's our job.
Yeah.
Okay, so with no further ado, we will end the session here.
We will
see you bright and breezy a week today for mental health.
Woo.
And we'll see you soon.
See you soon.
Bye.
Bye.
Hi, I'm Neil Bergman.
And I'm Hayley Bergman. Over the last 10 years, we've helped thousands of fitness professionals to get qualified, learn with simplicity, and coach clients with confidence.
We're the first to say that learning and being a FitPro doesn't have to be hard work, and that with the right structure, support and resources, you can become a confident and knowledgeable fitness professional that is dedicated to more.
So how do you learn, qualify and kickstart as a FitPro? This is the FitPro Session Podcast with Parallel Coaching.